For those of you who've heard my INSERS presentation recently, there'll be a little bit of repetition, but there are some twists, particularly in the immune-competent patients. Just to remind you that chickenpox infection is pretty ubiquitous up to the age of 50, where most of us have been infected with this virus and are therefore susceptible to zoster. Chickenpox virus settles in the dorsal root ganglion or the trigeminal ganglion, and decades later may re-erupt as zoster, characterized by neuritic pain and papulovesicular and then crusting rash. And that 1 in 3 people in a lifetime approximately will experience shingles, about 50% of people over the age of 85. And the figures for Australia are shown there. Now, the reason for the development of herpes zoster in the aging and the vulnerable, particularly the immune-compromised host, is this age-dependent decline in cell-mediated immunity to varicella zoster virus below a still undefined threshold that leads to a lack of immune control in the ganglia and at the skin, and ultimately to the presence of herpes zoster. Before that, there is boosting, probably mainly within family and also through asymptomatic infection, that actually maintains that T-cell immunity over the years. And I'll come back to this later on. So this leads to the increase in the incidence of herpes zoster over the age of 50 in virtually all OECD countries that have looked at this, is shown in this slide. And if we look at the Australian figures that we took out some years ago, you can see that same increase in herpes zoster in the black and grey bars, and an increase in post-herpetic neuralgia shown in the clear bars, particularly over the age of 70. So the complications of herpes zoster are post-herpetic neuralgia, defined as prolonged pain beyond 90 days. I'll show you the exact incidence of that in just a moment in various populations. Also herpes zoster ophthalmicus or ocular herpes zoster, affecting the periocular region at about 25% of people with zoster, but really only serious complications, as we showed in the placebo arm of our trials, 1.5%, and then the next commonest complication is that of disseminated cutaneous zoster. So it's not a disease without complications. And these, again, have been plotted from the placebo recipients in our vaccine trials, showing in people over the age of 50, about 12% will develop post-herpetic neuralgia, about 17% over the age of 70, and in people who've received stem cell transplants, 22%, which really hadn't been previously well defined. Sorry about that. See if I can go back. Yep. Too sensitive. And this just shows you the severity of the pain with acute and prolonged zoster, and on the right-hand side, the impairment of quality of life by herpes zoster in terms of mood, sleep, general everyday living, and we know indeed that herpes zoster can precipitate both hospitalization and irreversible admission to aged care. So if we look at the vaccine itself, just to remind you that this is a single recombinant protein with an adjuvant. The adjuvant is there initially to replace the other components of the virus that are missing. Glycoprotein E induces both antibody and T cell responses and is a key protein in the replication of the virus. But the adjuvant does more than just replace the components of the virus itself. And the adjuvant system consists of monophosphoryl A, which is an acylated A component from bacterial cell wall, and also QS21, a saponin from the bark of a South American tree. And the two are quite synergistic. If one excludes the adjuvant from the vaccine, as shown in the green bars on the right, then one only sees a T cell response in about 10% of people, 30% of people over the age of 70, 30% over the age of 60. But if you put the adjuvant back in, then you can see with the orange bars, with AS01B used at full dose in patients in the Shingrix immunization, then you get 90% people responding with T cell immunity. It may be of interest to you, the middle bar is the reduced dose of AS01, which is used in the RSV vaccine. And 2 doses are essential to get the full benefit of this immunogenicity. Otherwise, only about 2/3 of people will develop adequate T cell immunogenicity. So the trials, the pivotal trials that were run were Zoe 50 in people over the age of 50, Zoe 70 in people over the age of 70, to try and get an admixture of people at increased risk of post-herpetic neuralgia, and altogether about 30,000 people were trialed. And to our surprise, initially, in people over the age of 50, there was 97% efficacy over a period of 3.2 years, and in people over the age of 70, even in those over the age of 80, it was still 91%, and that persisted over 3.7 years. The complications, post-herpetic neuralgia and other complications, 90% efficacy. Essentially, the effects on the complications were in preventing herpes zoster itself. Unlike Zostavax, although the vaccine did reduce pain in the acute stages. When we look at durability of this vaccine, which is where other vaccines have had problems, we did a follow-up with a little gap, as you can see there, over up to year 12, and those follow-ups in this trial shown in grey were about half the numbers that we had in the original Zoe 50 and Zoe 70 trials. And these showed overall 89% efficacy over a period of 10 years. And you can see the year-by-year efficacies there, with an apparent drop from year 8 to 9 and 10. The new figures are coming out for year 11 in the near future. I would not take these figures as showing that there is a commencing decline at year 8. This was during COVID, and there were increased numbers of zoster cases during that period of time. And that's reflected in the T cell immunity, which has been shown to plateau and continue out to year 10. Now, the interesting thing recently is my colleague Adriana Weinberg and Kerry Lang in Denver and Seattle, respectively, have looked at the response, the immune response. And we'd always thought that this vaccine simply boosts the memory T cell response. You can see in blue that is not the case. You're actually seeing recruitment of naive or new T cells to glycoprotein E by this particular adjuvant, which is, I think, extremely interesting and certainly does raise the possibility of using this perhaps for chickenpox in immune-compromised kids. Now, I think you're all aware that it does have some drawbacks in terms of reactogenicity, with quite a large proportion of people getting injection site pain and then redness and swelling, as shown here. 9 to 10% of people getting grade 3 reactogenicity, that which impairs daily living. And if we look at the systemic reactogenicity with fatigue and other symptoms, again, the levels are quite high, a bit like the RNA vaccines, and again, about 9 to 10%. Much reduced in the RSV vaccine, I might mention. And the safety profile is excellent. I won't go into that in any great detail. There is a similar incidence of grade 3 reactogenicity after first and second doses, but if you have grade 3 reactogenicity after the first dose, you've only got a 1/3 chance of getting it after the second dose. So some of the most recent advances are shown here in the vaccine is efficacious in frail people. It ameliorates pain in the acute stages of breakthrough zoster. The retrospective effectiveness studies show a drop of about 15% if you use only a single dose, and the good immunogenicity of the vaccine does not require reactogenicity. There's no problem using the vaccine as a booster after Zostavax or after previous herpes zoster. And it can be co-administered with these vaccines usually used in the aging. Now, the vaccine actually works in the local lymph node. That's it actually drains from muscle into lymph node, where you get a cascade of immune responses resulting in antibody and T cells, which gives you, as shown on the right, this increased and broad immunity, and it's all about the adjuvant. When we look at the immune-compromised people, who are the other group at risk, we look at mild, moderate, and severe. It's really the moderate and severe group who are at risk of complications of herpes zoster and JAK inhibitors, and the live attenuated vaccine is contraindicated in these particular groups. And this just simply shows you the hierarchy of susceptibility of these different types of immune compromise. So hematologic malignancy, stem cell transplantation, solid organ transplant, and chemotherapy for solid tumors, and lastly, HIV. And there have been 5 trials run. Only 3 of them are phase 3, and the best of them is in stem cell transplantation. And when we look at the results, you can see in the panel, second from the right, that in hematologic malignancy, 87% efficacy, 68% with stem cell transplant, and about 68% with renal transplant. We need longer follow-up, and we need grade 3 trial, phase 3 trials in the other ones that haven't been tested as yet. The reactogenicity locally is about the same as immune-competent people. With systemic reactogenicity, it's increased, but that is due to the increased symptoms found in the underlying diseases. So it's not really all attributable to the vaccine itself. And in summary, 90% efficacy, unaffected by age. 2 doses are required. The duration of efficacy is out to 10 years, and the new results for that will be available, I think, within the next couple of months. The high reactogenicity is brief, 2 to 3 days of grade 3 reactogenicity, and only 1/3 will get it with a second dose. The risk of autoimmunity in gout with new adjuvants, none was seen in the trials, but we do know from epidemiologic studies that Guillain-Barré, at a rate of about 3 per million, like many other vaccines, influenza and adenovirus vaccines, has been identified. In severely immune-compromised patients, an efficacy of 68 to 87%, with local reactogenicity being similar. Thank you very much.
So we've got people online. So one question, Tony, is someone said they gave a shingles injection and a few weeks later the patient got shingles. I assume there's no association, but that was the question. And then secondly, how does that alter? What do you recommend for the follow-up one? Do you still give that as you would have, because you're halfway through a program?
Yeah, so of course we saw a number of people who got shingles between the first and second dose, and that's not surprising. Yeah, not surprising that we've actually got that you've seen that. I think that we recommend, there is no answer to that's where we have data for the second part of your question, but I think you'll find that Shingrix itself is probably actually better than getting shingles in terms of durability of response. Yeah.
And we've got time for questions, so we've got a panel. Alan, can we reserve that question for... No, do you want to do it now?
Tony, having a look at the relative efficacy of different age groups, has there been a study to determine, or cost effectiveness study to determine what's the optimal age to vaccinate? I think at the moment the vaccine is funded for over 70s, but giving vaccine in younger age groups where the incidence is starting to increase and with the longevity of the response, could it be cost effective to move that down?
Yeah, I think that's the $64 question. Currently, the recommendations are immunocompetent people over the age of 65 in the general community and over 18 for immune compromise. But obviously, if you've got a vaccine that goes 20 years and the price comes down, and I'll leave Katie to comment on that, then it becomes a matter of potentially using 2 doses in a lifetime from age 50. Which will be very exciting.